The elbow joint is a hinge type of synovial joint, and it's actually made up of two separate joints which work together as one. The first joint, called the humero-ulnar joint, is between the trochlea of the humerus and the trochlear notch of the ulna, and the second one, called the humero-radial joint, is situated between the capitulum of the humerus and the superior aspect of the head of the radius. A good way to remember this is thinking of the crazy tulips. The CRA in crazy represents the capitulum, which articulates with the radius, and the TUL in tulips represents the trochlea, which articulates with the ulna. The elbow joint is covered by a synovial membrane, which is surrounded by a joint capsule. The joint capsule extends from the margins of the articular surfaces of the capitulum and trochlea on the humerus to the coronoid process anteriorly and to the olecranon fossa posteriorly. On both the medial and lateral sides, the elbow joint is strengthened by two strong ligaments called the collateral ligaments, which are thickenings of the elbow joint capsule. On the medial side, also called the ulnar side, there's the ulnar collateral ligament, which extends from the medial epicondyle of the humerus to the coronoid process and the olecranon of the ulna. The ulnar collateral ligament actually consists of three separate bands: anterior, posterior, and oblique. The anterior band is the strongest, and it runs from the medial epicondyle to the tubercle of the coronoid process. This band helps limit elbow extension. Next, there's the fan-shaped posterior band, the weakest of all, and it runs from the medial epicondyle to the olecranon of the ulna. This helps limit elbow flexion. Finally, there is the thin oblique band, which makes the socket for the trochlea slightly deeper, reducing the chance of dislocation. On the lateral side, there's the radial collateral ligament, which extends from the lateral epicondyle of the humerus to the annular ligament which it blends with. The annular ligament encircles the radial head and binds it into the radial notch of the ulna, allowing for pronation and supination of the forearm. Now, the elbow joint is also surrounded by synovial fluid-filled bursae, which are basically pockets of synovial fluid that provide lubrication and reduce the friction when structures such as tendons, skin, muscles, and bones rub against each other with movement. There are three main elbow bursae. First, there's the subcutaneous olecranon bursa, which lies between the olecranon and the subcutaneous tissue. Then, the subtendinous olecranon bursa, situated between the tip of the olecranon and the triceps brachii tendon. And third, there's the intratendinous olecranon bursa, which lies within the triceps brachii tendon at the point of its insertion onto the olecranon. Finally, another important bursa, called the bicipido-radial bursa, is situated in the cubital fossa, which is a small, fat-filled, triangular space on the anterior aspect of the elbow. Specifically, the bicipido-radial bursa is situated between biceps brachii tendon and the tuberosity of the radius. As a hinge-type synovial joint, the elbow can do only two types of movements. That's what any hinge does, right? It opens and closes. The same goes for the elbow. This joint extends and flexes. Extension is mainly done by the triceps brachii, while flexion is mainly done by the brachialis and the biceps brachii muscles. The elbow joint receives its blood supply from the elbow's periarticular anastomosis, formed by the branches of the collateral and recurrent branches of the brachial artery, as well as the profunda brachii and the radial and ulnar arteries. Finally, regarding innervation, remember Hilton's law, which says that the nerves that innervate the muscles crossing over a particular joint also innervate that joint. So according to Hilton's law, the elbow joint is innervated by three nerves: the musculocutaneous nerve, the radial nerve, and the ulnar nerve. Before we wrap up, feel free to hit the pause button and see if you can remember the bands of the ulnar collateral ligament. Hint, there are three of them. Alright, as a quick recap, the elbow joint is a hinge-type synovial joint which allows flexion and extension of the elbow. On both the medial and lateral sides, the elbow joint is strengthened by the ulnar and radial collateral ligaments, respectively, which are thickenings of the elbow joint capsule that provide stability to the elbow joint. There are three main elbow bursae: the subcutaneous olecranon bursa, the subtendinous olecranon bursa, and the intratendinous olecranon bursa. Blood supply for the elbow joint comes from the periarticular anastomosis, while innervation is handled by the musculocutaneous, radial, and ulnar nerve.
The axilla, also known as the armpit, is first and foremost incredibly ticklish. But from an anatomical standpoint, it's a key location that contains many important structures that may be damaged, causing significant functional deficits. The axilla is like a train station, where a number of vascular, nervous, and lymphatic structures pass between the trunk and the upper limb. One very important structure is the brachial plexus, which can be divided into 5 roots, 3 trunks, 6 divisions, 3 anterior and 3 posterior cords, and 5 terminal branches. The order can be remembered using the mnemonic, "Remember to drink cold beer." But you may want to wait until at least the end of the video before you act on that. Now, an upper brachial plexus injury affects the superior root, namely spinal nerves C5 and C6. And a classic example of an upper brachial plexus injury is Erb palsy, which can happen in adults as a shoulder trauma that results in an increase in the angle between the neck and the shoulder, or in newborns, when excessive stretching of the neck occurs during childbirth. The clinical consequences reflect the affected nerves, which are the ones that are derived solely from C5 and C6 roots, namely the musculocutaneous, axillary, and suprascapular nerves. This causes paralysis of muscles like the biceps brachii, which normally allows forearm flexion and supination, and the infraspinatus and teres minor, so lateral rotation of the arm is affected, as well as the deltoid and supraspinatus muscles, which would usually cause arm abduction but would also be affected. So, with superior brachial plexus injuries, the classic finding is a waiter's tip position, which reflects arm adduction and medial rotation, and forearm extension and pronation. Lower brachial plexus injuries are much more uncommon, and they affect the interior roots of the brachial plexus, namely C8 and T1. This can happen because of excessive abduction of the arm, aka an increased angle between the trunk and the upper limb. This could happen to a person falling from a tree and grabbing onto a branch, or during delivery if the newborn is pulled out by the arm. The result is what's clinically known as Klumpke palsy, which has serious effects on nerves derived from the C8 and T1 roots, like the median and ulnar nerves, and causes loss of sensation along the medial side of the arm, and paralysis of the intrinsic hand muscles. The classic finding is a claw hand, which is due to flexion of the interphalangeal joints and extension of the metacarpophalangeal or MCP joints. This is mainly due to paralysis of the lumbricals, which normally act to flex the MCP joints and extend the interphalangeal joints as if you were to be waving bye-bye, resulting in unopposed flexion of the interphalangeal joints and unopposed extension of the MCP joints. Lower brachial plexus injuries can also occur due to compression of the lower trunk, for example, by an extra or cervical rib, or by an apical lung tumor called a Pancoast tumor. This is an example of thoracic outlet syndrome, and results in the same deficits as seen in Klumpke palsy. However, thoracic outlet syndrome can also result from damage to any structures that enter and exit the lower neck and upper limbs via the superior thoracic aperture, which is the region above the first rib between the clavicle, sternum, and cervical vertebrae. These structures include the subclavian vessels, which are usually compressed in the scalene triangle formed by the anterior and middle scalene muscles. The brachial plexus trunks, along with the subclavian artery, pass through this scalene triangle, where the subclavian vein travels anterior to it. Compression of the subclavian vessels results in upper extremity swelling and exertional arm pain. And speaking of compression, the radial nerve can also be affected by compression injuries. This happens when the radial nerve is compressed against the hard surface of the humerus, often occurring when we are sitting down and have our arms spread out over a chair next to us. This is commonly referred to as Saturday night palsy, because it might happen on a Saturday night if you fall asleep with your arm hanging over the chair. But it can also happen from any direct pressure on the radial nerve, for example, when using crutches. Spending an extensive amount of time in that position can cause weakness in elbow extension and wrist extension, classically known as wrist drop, in addition to loss of sensation over the dorsal hand and thumb, as well as the posterior forearm or arm, depending on how high up the nerve damage is. Finally, the axilla is also home to the axillary lymph nodes, which are often dissected and sent for pathologic analysis in the evaluation of breast cancer. Axillary nerve dissection, however, comes with a risk of long thoracic nerve injury, which clinically translates as a winged scapula. A winged scapula is more apparent when a person tries to push against a wall. The medial border and inferior angle of the scapula pull away from the posterior thoracic wall, making the scapula look like a wing. Besides protracting the scapula against the posterior thoracic wall, the serratus anterior also helps abduct the arm above the horizontal plane, so patients may have trouble doing overhead movements, like, for example, brushing their hair. Alright, as a quick recap. Superior brachial plexus injuries cause Erb palsy, and the classic finding is a waiter's tip position, which reflects arm adduction and medial rotation, as well as forearm extension and pronation. Inferior brachial plexus injuries cause Klumpke palsy, and the classic finding is a claw hand due to flexion of the interphalangeal joints and extension of the metacarpophalangeal joints. Compression of structures at the superior thoracic aperture can result in superior thoracic outlet syndrome, which often affects the lower trunks of the brachial plexus or subclavian vessels. Compression of the axilla can result in radial nerve palsy, resulting in wrist drop. Finally, the axilla is also home to the axillary lymph nodes, and during axillary lymph node dissection, damage to the long thoracic nerve may result in a winged scapula.
The vertebral column, commonly referred to as the spine or spinal column, consists of 33 vertebrae organized in 5 main regions: 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. The vertebrae come in different shapes and sizes, and they have unique features depending on their region. Typical vertebrae have a basic structure in common, consisting of a vertebral body, a vertebral arch, and 7 processes: a spinous process, 2 transverse processes, and 2 superior and 2 inferior articular processes. The vertebral body is the thick, cylindrical anterior portion of the vertebra, which functions in supporting weight. As you move down the spine, the vertebral bodies become larger as they bear more weight. Posterior to the vertebral body, there is the vertebral arch, which consists of 2 pedicles and 2 laminae. The pedicles are short, thick processes that project posteriorly from the vertebral body to meet the laminae, which are 2 broad, flat plates of bone that unite in the midline and complete the vertebral arch. The space between the walls of the vertebral arch and the vertebral body is called the vertebral foramen, and when you stack all the foramina on top of each other, that forms the vertebral or spinal canal, which forms a protective bony case around the spinal cord. Focusing on the 7 processes of the vertebrae, first we have the spinous process, which extends posteriorly from the midline junction of the laminae and serves as an attachment site for ligaments and muscles. Next, the left and right transverse processes. They extend posterolaterally from the junctions of the pedicles and laminae, while also serving as important attachment sites for ligaments and muscles. Finally, we have the 4 articular processes. First, there's the left and right superior articular processes, which project superiorly from the junctions of the pedicles and laminae. Next are the left and right inferior articular processes, which project inferiorly from the junctions of the pedicles and laminae. The superior articular processes, inferior articular processes, along with the pedicles, the vertebral bodies, and intervertebral discs between vertebral bodies, go on to create U-shaped indentations called the superior and inferior vertebral notch. So let's look at the articulation between two typical vertebrae from a lateral angle. The superior and inferior articular processes of each vertebra allow articulation with adjacent vertebrae via their articular facets. The inferior articular process of the top vertebra comes into contact with the superior articular process of the bottom vertebra, forming a zygapophyseal joint, also called a facet joint. The facet joints help keep the vertebrae properly aligned while also allowing movement of the vertebral bodies. Furthermore, their orientation differs throughout the vertebral column. This allows for different movements of the vertebral bodies in the cervical, thoracic, and lumbar regions. While still looking from a lateral view, you can also see how the inferior vertebral notch of the vertebra on top aligns with the superior vertebral notch of the vertebra below it to form a canal called the intervertebral foramen, through which the spinal nerves pass. Okay, before moving on, let's take a short break and see if you can recall the basic features of a typical vertebra. So now let's look at the common features of the typical vertebrae in each region. Cervical vertebrae can be typical or atypical. And when it comes to the cervical column, the typical vertebrae are C3, C4, C5, and C6, while the atypical vertebrae are C1, C2, and C7. The vertebral bodies of typical cervical vertebrae are smaller than the other regions, are wider from side to side, and have a concave superior surface and a convex inferior surface. The lateral edges of the superior surface of the vertebral bodies are each called the uncus of the body or the uncinate process. Now, what really makes cervical vertebrae stand out is that they have a foramen transversarium, or transverse foramen, which is an opening on each of the transverse processes. It's through these foramina that the vertebral arteries and corresponding veins pass. The lateral ends of the transverse processes have two projections, an anterior tubercle and a posterior tubercle, which are attachment sites for the levator scapulae and scalene muscles. The vertebral foramen of the cervical vertebrae is large and triangular shaped to accommodate the cervical enlargement of the spinal cord to fit through it. The facets on cervical vertebrae are nearly horizontal and as such allow for the most movement of all vertebral regions. The superior articular facets are directed slightly supero-posteriorly, meaning the facets face up and back slightly, while the inferior articular facets are directed slightly inferiorly and anteriorly, meaning the facets face down and forward slightly. This allows adjacent cervical vertebrae to sit nicely upon each other. The main movements the facet joint allows in the cervical region are free flexion and extension, some lateral flexion, and limited rotation. The spinous process of the cervical vertebrae are short, where typically C2 through C6 are bifid, meaning they have two protrusions at the posterior end that project posterolaterally. But let's not forget about the atypical cervical vertebrae. First, the C1 vertebra, also called the atlas, is a ring-shaped bone that doesn't have a body or spinous process. So instead of a body, it has paired lateral masses that serve as a body and sustain the weight of the globe-like cranium, just like the Atlas of Greek mythology, who bore the weight of the literal world on his shoulders. The transverse processes of the atlas arise from the lateral masses, so these processes are placed more laterally than those of the inferior vertebrae. This makes the atlas the widest of the cervical vertebrae. Now, the lateral masses have two superior, concave, kidney-shaped articular surfaces. These surfaces articulate with two large cranial protuberances on either side of the foramen magnum on the occipital bone, called the occipital condyles, to form the atlanto-occipital joint. The anterior and posterior arches extend between the lateral masses and form a complete ring. The anterior arch has an anterior tubercle and a facet for the dens, and the posterior arch has a posterior tubercle and a groove for the vertebral artery. On the anterior arch, there's a tubercle for the transverse ligament. The transverse ligament extends from one lateral mass to the other lateral mass on the atlas, passing between the spinal cord and the dens, which is a part of the C2 vertebra. Speaking of which, the C2 vertebra is also called the axis because it has a blunt tooth-like dens or odontoid process. The dens projects superiorly and articulates with the posterior surface of the anterior arch of the atlas, and it's held in place by the transverse ligament. Next, C2 also has two large, flat, weight-bearing surfaces called the superior articular facets, on which the atlas rotates. It also has inferior articular processes and transverse processes similar to the other cervical vertebrae. Finally, C7 has a smaller transverse foramen than the other cervical vertebrae, and it's also called the vertebra prominens due to its long spinous process. In most people, it is the most prominent spinous process, and you can actually feel it if you run your finger and press along the midline of the back of your neck. Okay, I prominens we're done articulating the multifaceted details of the cervical vertebrae for now. Take a moment to see if you can recall the key structures of the typical and atypical cervical vertebrae. All right, next up are the thoracic vertebrae, which are located in the upper and middle back, between the cervical and lumbar vertebrae. They are intermediate in size, though they do get bigger further down the vertebral column. On a quick glance, an easy way to identify the thoracic vertebrae is from a posterior lateral view, where they look like a giraffe. This is compared to the lumbar vertebrae, which we will talk about shortly, which look like a moose. From a superior view, the typical thoracic vertebrae, which are T2 through T11, have a heart-shaped vertebral body, a vertebral foramen that is circular and small, and a pair of transverse processes that are long, strong, and extend posterolaterally. Let's look at a typical thoracic vertebra from a lateral view. The facets of the superior articular processes are nearly vertical and face posteriorly and slightly laterally, while the facets of the inferior articular processes are also nearly vertical, but face anteriorly and slightly medially. The unique orientation of the facets allows adjacent thoracic vertebrae to articulate nicely. This orientation also results in the main movement of rotation and some lateral flexion of the thoracic vertebrae. The spinous process of a typical thoracic vertebra is long and slopes postero-inferiorly, overlapping with the inferior vertebra. The most characteristic features of the thoracic vertebrae are the two superior and two inferior costal facets, which articulate with the heads of the ribs. These are known as demifacets, as they are half of a facet, with two demifacets articulating with the head of a single rib. There's also one costal facet on the anterior side of each of the transverse processes, called the transverse costal facet, which articulates with the tubercle of the ribs. And now, just a few words on the atypical thoracic vertebrae features, which are T1 and T12. T1 is similar to the C7 vertebra, so it has a long, nearly horizontal spinous process, similar to that of C7. Furthermore, the superior costal facet of T1 is a complete costal facet and not a demifacet when articulating with the first rib, where its inferior costal facet is a demifacet for the upper half of the head of the second rib. T12, on the other hand, has quite a bit in common with its downstairs neighbors, the lumbar vertebrae. Its upper half is more thoracic-like, having costal facets and articular processes that permit mainly rotational movements between it and the vertebrae above. Its lower half is more lumbar-like, with the body and pedicles being larger and thicker, as well as having a shorter, more horizontal spinous process. Furthermore, the inferior articular processes are more laterally facing, which means the movements between T12 and L1 are flexion and extension, not rotation. Since T12 is sort of caught in between the somewhat inflexible thoracic region and more flexible and mobile lumbar region, this vertebra is subject to increased transitional stress. This makes T12 the most commonly fractured vertebra. Okay, take a moment to see if you can recall the key structures of the typical and atypical thoracic vertebrae. All right, next up are the lumbar vertebrae, which are in the lower back, between the thoracic vertebrae and the sacrum. They are the largest movable vertebrae, which helps with bearing the weight of the upper body. They have a massive, thick, and strong body, which is fitting because, as we said before, from a posterior view, they look a lot like a moose, and that animal also has a massive, strong body. Typical lumbar vertebrae also have a triangle-shaped vertebral foramen, which is bigger than the thoracic vertebrae, but smaller than the cervical vertebrae. The lumbar vertebrae also have long, slender, transverse processes that extend laterally and short, broad, sturdy, spinous processes. The superior articular facets are in the sagittal plane, mainly facing medially and a little posteriorly, while the inferior articular facets are also in the sagittal plane, mainly facing laterally and slightly anterior, allowing each lumbar vertebra to articulate well with the adjacent vertebrae. On the posterior surface of each of the superior articular processes, there are small tubercles called the mammillary processes that are characteristic of lumbar vertebrae. The mammillary processes project posteriorly and allow for attachment to the multifidus and intertransversarii muscles. There's another process called the accessory process, also characteristic of lumbar vertebrae, on the posterior surface of the base of each transverse process. The accessory process provides an attachment for the intertransversarii muscles. Now let's look at an atypical lumbar vertebra. Among the lumbar vertebrae, L5 is atypical in that it is the largest of the movable vertebrae, with the most massive body and transverse processes. This is because it carries the weight of the whole upper body. Its body is also taller anteriorly. Furthermore, the facets of the L5-S1 joint are more coronal in orientation, allowing for flexion and extension, along with some lateral flexion. Okay, let's stop moosing around and pause for a quick moment to see if you can recall the key structures of the typical and atypical lumbar vertebrae. All right, now let's look at the sacral region. The sacrum is a triangular bone made up of 5 fused sacral vertebrae in adults. It's located between the lumbar vertebrae and the coccyx in the vertebral column, right between the hip bones. It stabilizes the pelvis and transfers weight to the pelvic girdle. The sacrum is thick and wide across its base, where it plays a role in weight bearing, but it tapers down inferiorly towards its apex, where it does not bear weight. From an anterior view, we can see how the sacrum resulted from the fusion of the 5 sacral vertebrae, as we notice the 4 transverse ridges that indicate the divisions between what originally was the 5 individual sacral vertebrae, S1 through S5. The wide base of the sacrum is derived from S1, and on each side it extends laterally as a wing-like structure called the ala, which is Latin for wing. The anterior lip of the body of S1 is called the sacral promontory, which marks the border of the pelvic inlet. Inferiorly, we can see 4 pairs of anterior or ventral sacral foramina that lie lateral to each vertebral body and allow for the passage of the anterior rami of sacral spinal nerves. These foramina extend to the posterior aspect of the sacrum. From a posterior aspect, they are referred to as the posterior or dorsal sacral foramina. Also in the posterior view, we can see the superior articular processes of S1 and their corresponding superior articular facets on the dorsal aspect, which articulate with the inferior articular facets of L5 at the lumbosacral angle, which can vary between 130 and 160 degrees. The lateral surfaces of the superior half of the sacrum look a bit like ears and are aptly called the auricular surfaces. These auricular surfaces articulate with the ilium to form the sacroiliac joint. In the center of the sacrum, there's the sacral canal, which is the continuation of the vertebral canal. The sacral canal contains the spinal nerve roots that make up the cauda equina, the bundle of nerves protruding from the bottom of the spinal cord. Along the midline of the posterior surface of the sacrum is the medium sacral crest, which is the remnant of the fused spinous processes of S1 to S3, or sometimes S4. The intermediate sacral crests that lie just lateral to either side of the median crests are remnants of the fused articular processes of the sacral vertebrae. Finally, the lateral sacral crests lie further laterally on each side, and they arise as a result of fusion of the transverse processes of the sacral vertebrae. Because S5 doesn't have a spinous process, nor laminae, that results in an upside-down U-shaped opening in the wall of the sacral canal called the sacral hiatus. A bit further inferiorly, there are the sacral cornua, a pair of projections just lateral of the midline, which are remnants of the inferior articular processes of the S5 vertebra. And finally, there's the coccyx, or tailbone, which is a small, triangle-shaped bone derived from the fusion of the 4 rudimentary coccygeal vertebrae at the very bottom of the vertebral column. The anterior surface of the coccyx is smooth and slightly concave. The posterior surface is convex and has rudimentary articular processes. The coccyx serves as a site for attachment for parts of the gluteus maximus, coccygeus muscles, and the anococcygeal ligament. Whew, that was a lot. Take a short break and see if you can recall the key features of the sacrum and the coccyx. All right, as a quick recap, the vertebral column consists of 33 vertebrae organized into 5 regions, with 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. Generally speaking, the vertebrae across the different regions have some key components in common, including the vertebral body, pedicles, laminae, transverse processes, articular processes, and a spinous process. Cervical vertebrae are the smallest movable vertebrae with rectangular vertebral bodies, large triangle-shaped vertebral foramen, bifid spinous processes, and a pair of transverse foramina, which are specific to the region. The atypical cervical vertebrae are C1, the atlas, C2, the axis, and C7, the vertebra prominens. Thoracic vertebrae are a bit bigger than cervical vertebrae and increase in size down the column. They look like giraffes and have a heart-shaped vertebral body, a small circular vertebral foramen, long transverse processes, downward sloping spinous processes, and costal facets on the vertebral bodies and transverse processes, which are unique to the region. The atypical thoracic vertebrae are T1 at the top of the region, which appears to be more cervical-like, and T12 at the bottom of the region, which appears to be more lumbar-like. Lumbar vertebrae are the largest and strongest movable vertebrae, which is important since they bear the most weight, and remember, they look like a moose. They have distinctly massive vertebral bodies, medium-sized triangular vertebral foramen, slender transverse processes, and mammillary processes characteristic of the region. L5 is the lone atypical lumbar vertebra, with its massive body that is taller anteriorly, accounting for the lumbosacral angle. The sacrum and coccyx are the triangle-shaped bones at the bottom of the column that form from the fusion of the individual vertebrae that make them up.
The pelvic girdle, or the bony pelvis, is a bony ring formed by the left and right hip bones and the sacrum, and it surrounds the pelvic cavity and connects the vertebral column to the lower limbs. The main function of the pelvic girdle are to transfer the weight of the upper body to the lower limbs when sitting or standing and provide attachment points for muscles that help with locomotion and posture. It also provides support and protection for the abdominopelvic structures. So let's start with the hip bones. The right and left hip bones are irregular shaped bones located at the sides of the pelvic cavity, which bound and form the lateral walls of the pelvis. Each one of these hip bones developed from the fusion of three bones: the ilium, ischium, and pubis. Now let's start with the upper part of the hip bone, the ilium. You can think of the ilium as a fan. It has an upper expanded part representing the spread of the fan, called the ala, and a lower narrow part representing the handle of the fan, called the body. Now, there are 4 bumps coming off the ilium called spines. Let's talk about them. If we look anteriorly to the ilium, we can see 2 of the spines. One of them is superior, and the other one is inferior. The naming is easy because it follows the rule of anterior or posterior plus superior or inferior. The superior one is called the anterior superior iliac spine, and the inferior one is called, you guessed it, the anterior inferior iliac spine. Now, looking at the ilium from a posterior view, we can see the remaining 2 spines, one superior and, again, one inferior. If we follow the rule just mentioned, we can name them easily. The superior one is called the posterior superior iliac spine, and the inferior one is called, wait for it, posterior inferior iliac spine. The main function of the spines is to provide attachment points for various muscles. For example, the longest muscle in the body is called the sartorius, and it attaches to the anterior superior iliac spine. Now, let's move to the next part of the ilium, the iliac crest, which is the rough, curved uppermost part of the ilium, representing the rim of the fan. The iliac crest runs between the anterior superior iliac spine and the posterior superior iliac spine. Now, when looking at the anteromedial surface of the ilium, we can see a fossa called the iliac fossa. This fossa is covered by a muscle called the iliacus. From a posteromedial view, we can see the auricular surface of the ilium. Right and left auricular surfaces of both ilia articulate with the sacrum, forming 2 sacroiliac joints. Above the auricular surface, there's an even rougher bit of bone called the iliac tuberosity, which has synovial and syndesmotic articulation with the reciprocal surface of the sacrum. Posteriorly, the ilium presents the gluteal surface. This surface is covered by 3 muscles called gluteus muscles. These muscles originate from lines on the gluteal surface of the ilium called posterior, anterior, and inferior gluteal lines. The gluteus minimus originates between the anterior and inferior gluteal lines. The gluteus medius originates between the anterior and posterior gluteal lines. And finally, the posterior gluteal line forms part of the origin of the gluteus maximus, which is the largest of the gluteal muscles. Moving on to the next part of the hip bone, the ischium. The ischium has 2 main parts, a body and a ramus. The body is the superior expanded part of the ischium that connects to the ilium superiorly and to the pubis anteriorly, and helps to form the acetabulum. The ramus is the lower, narrow part of the ischium that connects anteriorly to the lower part of the pubis, and helps form part of the obturator foramen. On the infero-posterior part of the ischium, there's a large, roughened area called the ischial tuberosity, which supports our weight while sitting, and where the inferior gemellus muscle and the hamstrings attach. At the junction of the body and ramus, there's a pointed projection called the ischial spine, where the sacrospinous ligament and superior gemellus muscle originate. Below the ischial spine, specifically between it and the ischial tuberosity, there's an arc called the lesser sciatic notch, and above the ischial spine is the greater sciatic notch, which is formed by parts of both the ischium and the ilium. Alright, now let's move on to the third and final part of the hip bone, the pubis. The pubis has three parts: a body, superior ramus, and inferior ramus. The body of the pubic bone is the thickest, most anterior part of the pubic bone. The superior ramus of the pubis connects to the ilium, forming the iliopubic ramus. The inferior pubic ramus connects to the inferior ramus of the ischium, forming the ischiopubic ramus. The angle at which both of these converge is called the pubic arch. Next is the pubic crest, which is a thickening on the anterior part of the pubis where the abdominal muscles attach. It has a swelling on its lateral side called the pubic tubercle, which is the distal attachment point of the inguinal ligament. The pectineal line, or pecten pubis, is an oblique ridge located on the lateral part of the superior pubic ramus, and it's where the pectineus muscle originates from. Anteriorly, the bodies of the right and left pubic bones are joined together in the median plane through a fibrocartilage called the interpubic disc. This connection forms a joint called the pubic symphysis. The pubic symphysis is a secondary cartilaginous joint that is supported superiorly by the superior pubic ligament, which connects the pubic bodies to the interpubic disc, and inferiorly by the inferior pubic ligament, which forms the apex of the pubic arch. When the bodies of the two pubic bones meet, they form an angle inferiorly called the subpubic angle. The pubic symphysis is important in stabilizing the pelvic girdle and transferring weight from the upper body to the lower body, and it undergoes important changes during childbirth to allow the fetus to pass through the birth canal. Now, looking at the hip bone from a lateral view, we can see a deep cup-shaped fossa called the acetabulum. This fossa is formed by the body of the ilium, the body of the ischium, and the superior ramus of the pubis. The head of the femur fits into this fossa, forming the hip joint. And right below the acetabulum, there's the obturator foramen. The obturator foramen is bound by the ramus of the ischium and the inferior ramus of the pubis, and it's partially covered by the obturator membrane. The small part of the obturator foramen that's not covered by the membrane is called the obturator canal, through which the obturator nerve and obturator blood vessels pass to supply structures in the medial compartment of the thigh. Also, the obturator membrane gives origin to two muscles, called the obturator internus and externus muscles. Now let's take a quick break. Pause the video and see if you can recall some of the most important features of the ilium, ischium, and pubis. Alright, now let's switch gears and talk about the sacrum. The sacrum is a wedge-shaped bone composed of 5 fused sacral vertebrae. The sacrum forms the posterior-superior wall of the pelvic cavity, and it has a superior base and an inferior apex. The base of the sacrum is formed by the superior surface of the S1 vertebra. Now, in its uppermost portion, the S1 vertebra has an anterior lip called the sacral promontory, which arches a bit towards the front. And on both sides, the sacral vertebrae extend laterally to form the sacral ale. The apex of the sacrum, its tapering inferior end, articulates inferiorly with the coccyx, forming the sacrococcygeal joint. This joint is a secondary cartilaginous joint, and is supported by the anterior and posterior sacrococcygeal ligaments. Alright, now the sacroiliac joints connect the sacrum to the hip bones, and they actually consist of 2 joints. An anteriosynovial joint, which is formed by the articulation between the sacrum and the auricular surfaces of the ilium, and a posterior syndesmosis joint, formed by the articulation between the tuberosities found on the posterior surfaces of the ilium and the sacrum. The synovial portion is unlike other synovial joints as it has very limited mobility. But that's because their main role is to transmit the weight of the body into the hip bones. The sacroiliac joint is supported by multiple ligaments, including the anterior and posterior sacroiliac ligaments, which is synonymous with the fibrous synovial capsule, and they support the joint anteriorly and posteriorly. A third sacroiliac ligament, the interosseous sacroiliac ligament, is a primary structure involved in transferring weight and lies between the sacral and iliac tuberosities in the anterior synovial joint. There's also the sacrotuberous ligament, which goes from the posterior surface of the ilium and the lateral surfaces of the sacrum and the coccyx to the ischial tuberosity. And that's why it's called the sacro, referring to the sacrum, and tuberous, referring to the ischial tuberosity ligament. See? A lot of these ligaments are named based on their origin and insertion points, making them easier to remember. A similar ligament, called the sacrospinous ligament, passes from the lateral surface of the sacrum and the coccyx to the ischial spine. These two ligaments convert the greater and lesser sciatic notches into the greater and lesser sciatic foramina, as shown here. There are multiple important structures passing through these two foramina. For example, the sciatic nerve passes through the greater sciatic foramen to enter the posterior thigh. This nerve and its branches supply structures in the back of the thigh and the leg. Finally, the iliolumbar ligament binds the fifth lumbar vertebrae to the iliac crest of the ilium. The sacrotuberous, sacrospinous, and iliolumbar ligaments are called the vertebropelvic ligaments because they bind parts of the vertebral column to the hip bones. All right, I know that was a lot. Take a deep breath. And let's move on to the pelvis itself. The pelvis has a superior opening called the pelvic inlet and an inferior opening called the pelvic outlet. Both the sacrum and the hip bones participate in forming these openings. The bony edge defining the pelvic inlet is called the pelvic brim. Posteriorly, there's a sacral promontory and the ala of the sacrum. Laterally, there's a linea terminalis, which is composed of the arcuate line of the ilium and pecten pubis. Anteriorly, the pelvic brim is formed by the pubic symphysis. On the other hand, the pelvic outlet is bounded by the tip of the coccyx posteriorly, the inferior margin of the sacrotuberous ligament posterolaterally, and ischial tuberosities laterally, and the pubic arch anteriorly. Now the pelvic inlet divides the pelvic cavity into an upper, larger area called the greater or false pelvis, and a smaller, lower area called the lesser or true pelvis. Each part of the pelvis has its own boundaries. Let's start with the greater or false pelvis. The greater pelvis is superior to the pelvic inlet and defined by the ala of the ilium posterolaterally, and by the first sacral vertebra posteriorly. It contains the ilium and the sigmoid colon. The lesser pelvis is between the pelvic inlet and outlet, and is bounded by the hip bones, sacrum, and coccyx, and contains organs of the urinary and genital systems. Now, in anatomical position, the pelvis is tilted in the anterior-posterior plane in a way that makes the right and left anterior-superior iliac spines in the same plane as the pubic symphysis. This anterior pelvic tilt makes the pubic bones appear to be located inferiorly instead of anteriorly, making the pubic bones and pubic symphysis the main weight-bearing contributors. This also means the pelvic inlet is more vertical than horizontal. Also, this orientation of the pelvis makes the superior surface of the sacrum visible when looking at the pelvis from an anterior view. Furthermore, the acetabulum faces inferior laterally and articulates with the head of the femur, and the obturator foramen is inferior medial to the acetabulum. Finally, there are differences between male and female pelvis. These differences are mainly due to the heavier build and larger muscles of men compared with the female pelvis, which is adapted for childbirth. The male pelvis is thick and heavy compared to the female pelvis, which is thin and light. The lesser or true pelvis is narrow and deep in males, but wide and shallow in females. Also, in males, the pelvic inlet is heart-shaped, while in females it's oval-shaped. The pelvic outlet is comparatively small in males, but large in females, to give the fetus enough room to come out of the pelvis. Finally, there are differences between the male and female pelvis, which is below 70 degrees in males, but is more than 80 degrees in females. But these differences are not solely the interest of obstetrics and gynecology specialists. Other medical specialties, such as forensic medicine, use these facts to determine the gender of skeletal remains. However, remember that even though there are some differences between the male and female pelvis, the pelvis of any person may have some features of the opposite sex. Alright, as a quick recap, the pelvic girdle is composed of 3 bones, the 2 hip bones and the sacrum, and it connects the vertebral column to the lower limbs. Each hip bone is composed of 3 parts, the ilium, ischium, and pubis. Also, the 2 hip bones are connected posteriorly to the sacrum and anteriorly to each other through the pubic symphysis. The sacrum is connected to the ilia through the sacroiliac joints. These joints are supported by the sacrospinous and sacrotuberous ligaments, which help form the boundaries of the greater and lesser sciatic foramina. The pelvic cavity has a superior entrance called the pelvic inlet, and an inferior exit called the pelvic outlet. The pelvic inlet splits the pelvis into the greater and lesser pelvis. Now, in an anatomical position, the pelvic girdle is tilted in a way that brings the anterior superior iliac spine and the pubic symphysis line in the same plane. Finally, the male and female pelvises are different because males have a larger muscle mass, so their pelvis is thicker and heavier, while the female pelvis is adapted to childbirth, so it has a more spacious lesser pelvis and a larger pelvic outlet.
The pelvic cavity is a funnel-shaped space surrounded by pelvic bones, and it contains organs, such as the urinary bladder, rectum, and pelvic genitals, to name a few. The pelvic cavity and the abdominal cavity together form the larger abdominopelvic cavity. The pelvic cavity is bounded superiorly by the pelvic inlet, which connects to the abdominal cavity, and inferiorly it's bounded by a group of muscles and the fascia surrounding them, called the pelvic floor or pelvic diaphragm, which is suspended above the pelvic outlet, with its central portion dipping below it. The pelvic cavity also has an antero-inferior wall, 2 lateral walls, and a posterior wall. So let's start with the antero-inferior wall, formed by the bodies and rami of pubic bones, and the pubic symphysis. Each pubic bone has 3 parts, a body, and a superior and inferior ramus. The body of the pubic bone is the thickest, most anterior part of the pubic bone. Anteriorly, the bodies of the right and left pubic bones are joined together in the median plane to form the pubic symphysis. Now, in an anatomical position, the pelvis is tilted in the anterior-posterior plane, making the pubic bones and pubic symphysis act more like a weight-bearing floor than an anterior wall. The lateral walls of the pelvic cavity are formed by the right and left hip bones. Each hip bone has an inferior opening called the obturator foramen, which is formed by the pubis and the ischium. The foramen is partially covered by a membrane called the obturator membrane. This membrane and the pelvic surfaces of the ilium and ischium give origin to a muscle called the obturator internus, which pads most of the lateral pelvic wall. Now, the fibers of the obturator internus muscle converge posteriorly to become tendinous, and then travel through a foramen called the lesser sciatic foramen. Finally, they attach to a large area on the lateral side of the femur called the greater trochanter. The medial surfaces of the obturator internus are covered by a fascia called the obturator fascia. This fascia covers most of the muscle and becomes thicker medially to form a tendinous arch. This arch gives origin to one of the muscles forming the pelvic floor or pelvic diaphragm. Additionally, the attachment of the pelvic diaphragm to the obturator fascia divides the obturator internus into a superior pelvic portion and an inferior perineal portion. Now let's move on to the posterior wall. The posterior wall has a bony and a musculoligamentous part. The bony part is formed by the sacrum and coccyx, which are the final parts of the vertebral column. The sacrum is a wedge-shaped bone composed of 5 fused sacral vertebrae. It forms the posterosuperior wall of the pelvic cavity and has a superior base and an inferior apex. Also, the sacrum connects to the hip bones on both sides, forming the sacroiliac joints. The anterior and posterior sacroiliac ligaments support this joint anteriorly and posteriorly. Next, there's the coccyx, also called the tailbone, which is a small triangular bone formed by the fusion of 4 vertebrae. Inferiorly, it attaches to the apex of the sacrum and forms the last part of the vertebral column. Ever wondered why it's called the tailbone? Well, that's because the coccyx is the remnant of a tail-like structure found in human embryos between weeks 4 and 8, called the caudal eminence. But it's not just an embryonic remnant. Multiple structures attach to the coccyx. These include parts of the gluteus maximus and coccygeus muscles, and a ligament called the anococcygeal ligament. Now, as the name suggests, the musculoligamentous part of the posterior wall is composed of muscles and ligaments. The piriformis is the main muscle which forms the posterolateral walls of the pelvic cavity. It originates from the superior part of the sacrum, goes through a foramen called the greater sciatic foramen, and finally attaches to the superior border of the greater trochanter of the femur. The ligaments that form the posterior wall are the anterior-sacroiliac, sacrotuberous, and sacrospinous ligaments. The anterior sacroiliac ligament is one of the ligaments that supports the sacroiliac joints anteriorly. The sacrotuberous ligament passes from the posterior surface of the ilium and the lateral surfaces of the sacrum and coccyx to the ischial tuberosity. Finally, the sacrospinous ligament passes from the lateral surface of the sacrum and the coccyx to the ischial spine. The pelvic floor, or pelvic diaphragm, is musculofascial, meaning that it is composed of a group of muscles and the fascia covering them, called the fascia of the pelvic floor. The pelvic floor separates the pelvic cavity superiorly from the perineum inferiorly, which is the space between the anus and the scrotum in males and between the anus and the vulva in females. The muscles that form the pelvic diaphragm are the coccygeus and the levator ani. The coccygeus are triangular muscles that run from the ischial spine to the lateral surfaces of the sacrum and coccyx. These muscles are innervated by branches of spinal nerves S4 and S5, and each coccygeus muscle flexes the coccyx anteriorly, helping it bear the body weight while sitting. Now, the levator ani muscle is the larger muscle forming the pelvic floor. Each levator ani originates anteriorly from the body of pubic bones and to the ischial spines posteriorly. Between these two bony origins, each levator ani muscle attaches to the tendinous arch of the levator ani, which is a medial thickening of the obturator fascia called the tendinous arch of the levator ani. The pelvic diaphragm spans between the anterior, lateral, and posterior walls of the pelvis, closing most of the pelvic girdle ring, but it leaves a small gap anteriorly just behind the pubic bones called the urogenital hiatus. In females, the vagina passes through this gap, as well as the urethra in both females and males. The levator ani forms the dynamic floor that supports the abdominopelvic viscera. And most of the time, it's contracted to assist in maintaining urinary and fecal continence. So basically, it helps us hold it in until we can get to the bathroom, or a bush where no one's looking. It also contracts during forced expiration, sneezing, coughing, and vomiting to increase viscera support during times of increased intra-abdominal pressure. And finally, it relaxes in order to allow urination or defecation. Alright, now the levator ani muscle consists of 3 parts: puborectalis, pubococcygeal, and iliococcygeal. All three are innervated by the nerve to levator ani coming from branches of S4, the inferior anal nerve, and coccygeal plexus. The puborectalis is the thicker, narrower, medial part of the levator ani, and it bounds the urogenital hiatus from both sides. And its name kind of gives away the whole story. Pubo means that this part attaches to the posterior surfaces of the bodies of the pubic bones anteriorly, and rectalis means that this part forms a sling around the ano-rectal junction. Easy, right? The puborectalis is U-shaped, with the tips of the U attached anteriorly to the posterior surfaces of the bodies of both pubic bones. The bowl of the U forms a puborectal sling around the junction between the rectum and the anus, called the ano-rectal junction or flexure. So, when all is said and done, the puborectalis plays a major role in maintaining fecal continence. Next, there's the pubococcygeus, which is the wider, thinner, intermediate part of the levator ani muscle. This part arises lateral to the puborectalis, from the posterior surfaces of the bodies of pubic bones, in addition to the anterior tendinous arch. The lateral muscle fibers go posteriorly to attach to the coccyx, hence its name, pubococcygeus. The medial muscle fibers of the paired pubococcygeus muscles fuse in midline to form a median tendinous raphe, which forms part of the anococcygeal body, or ligament between the anus and coccyx, often referred to as the levator plate. This raphe unites with the external anal sphincter, forming a ligament that extends between the coccyx and the anus, called the anococcygeal body, or ligament. The main action of the pubococcygeus muscle is to maintain urinary continence and help in male ejaculation. Finally, there's the iliococcygeus, which is the posterolateral part of the levator ani. This part arises from the ischial spines and tendinous arch, and inserts on the coccyx and anococcygeal body. It is usually thin and poorly developed, and it usually looks like a fibrous tissue rather than muscle fibers. Alright, as a quick recap. The pelvic cavity is a funnel-shaped cavity bounded superiorly by the pelvic inlet, and inferiorly by the pelvic floor or diaphragm. It has an antero-inferior wall, two lateral walls, and a posterior wall. The antero-inferior wall is formed by the bodies and rami of pubic bones. The lateral wall is formed by the obturator membrane and the obturator internus muscle. Finally, the posterior wall is formed by the sacrum and coccyx, and the anterior sacroiliac, sacrotuberous, and sacrospinous ligaments. The pelvic floor contains two muscles, the coccygeus and the levator ani. Those muscles support the pelvic viscera and help in maintaining fecal and urinary continence.
The small intestine is a part of the digestive tract specialized in absorbing nutrients and minerals from the food we eat. It's located in the abdominopelvic cavity, and it begins at the pylorus of the stomach, and it ends at the ileocecal junction, where it continues with the large intestine. It has three major components: the duodenum, which can be divided into four parts, the jejunum, and the ileum. Now, when talking about structures of the abdomen, we often encounter the terms retroperitoneal or intraperitoneal. Retroperitoneal is a description for abdominal structures that are only partially covered by peritoneum and lie posterior or behind the abdominal peritoneum, where intraperitoneal means that these structures have invaginated and are completely covered by the visceral peritoneum. So, of these components, the proximal portion of the first part of the duodenum, in addition to the jejunum and ileum, are intraperitoneal, where the distal portion of the first part of the duodenum, in addition to the second, third, and fourth parts of the duodenum, are retroperitoneal, and are found posteriorly in the retroperitoneal cavity. That being said, let's have a closer look at the duodenum and its four parts. Overall, the duodenum is shaped like the letter C, curving around the head of the pancreas, and consists of the first or superior part, second or descending part, third or inferior part, and fourth or ascending part. The first part lies in the transverse plane and begins anterolaterally to the right of the L1 vertebral body, continuing to the pylorus. The proximal portion of the first part has a segment of the lesser omentum called the hepatoduodenal ligament attached to its superior surface, and the greater omentum attached to the inferior surface. The proximal 2 centimeters of the first part is also more dilated and freely mobile, as it is intraperitoneal with its anterior and posterior surface covered in peritoneum, and is referred to as the ampulla or the duodenal cap. This is in contrast to the distal 3 centimeters, which is retroperitoneal and therefore not mobile. The first part of the duodenum travels laterally to the right and has the liver and gallbladder overlying it, and it has the IVC, bile duct, and gastroduodenal artery posterior. The second part, or descending part of the duodenum, is completely retroperitoneal. It curves downward around the head of the pancreas, which is medial, and runs inferiorly from the L1 to the L3 vertebra, to the right of and parallel to the IVC. Overlying the second part is the transverse colon and the convolutions of the small intestine. Where posterior to it, there's the hilum of the right kidney, its vessels, and ureter. If we open up the second part of the duodenum and look inside, we can see the major duodenal papilla on its posteromedial wall. That's where the main pancreatic duct combines with the common bile duct to form a hepatopancreatic ampulla, which carries the pancreatic juices and bile to the duodenum. Of note, these can also be referred to as the papilla of Vater and ampulla of Vater respectively, not to be confused with the popular Darth Vader. Sometimes, above the major duodenal papilla, there is also a minor duodenal papilla where the accessory pancreatic duct opens. The duodenum then turns to the left, and the third part starts at the level of L3. This part is also completely retroperitoneal. The third part of the duodenum passes horizontally to the left below the head of the pancreas. Posterior to it are the inferior vena cava, or IVC, the aorta, the proximal parts of the inferior mesenteric vessels, and the body of the L3 vertebra. Anterior to the inferior part, there are the superior mesenteric artery, or SMA, the superior mesenteric vein, or SMV, and parts of the jejunum. Finally, the duodenum turns upwards and becomes its fourth part, called the ascending part, which ascends to the left of the L3 vertebra and aorta, up to the L2 vertebral level and the inferior border of the pancreas. Medial to the fourth part, there are the SMA, SMV, and uncinate process of the pancreas. Then it turns anteriorly to connect with the jejunum, forming the duodenojejunal flexure, or junction, at the level of L2. This site hangs by the suspensory muscle of the duodenum, also known as the ligament of Treitz, that is made out of the skeletal muscles from the diaphragm and the smooth muscles of the duodenum. Now, the duodenum mainly gets arterial blood from the celiac trunk and the SMA. The celiac trunk gives off the common hepatic artery, which also gives rise to the supraduodenal artery supplying portions of the first and second duodenal parts, and the gastroduodenal artery, which has a branch called the superior pancreaticoduodenal artery that supplies the first two parts of the duodenum up until the major duodenal papilla. The SMA, on the other hand, gives off a branch called the inferior pancreaticoduodenal artery, which supplies the other two parts of the duodenum distal to the major duodenal papilla. The superior and inferior pancreaticoduodenal arteries give anterior and posterior branches that connect with each other, forming anastomoses between the celiac trunk and the SMA. The veins of the duodenum drain alongside the arteries, and venous blood is collected by the splenic and superior mesenteric vein, which eventually drain into the hepatic portal vein. The lymphatic vessels of the duodenum accompany arteries as well, and drain via the pancreaticoduodenal lymph nodes located along the superior and inferior pancreaticoduodenal arteries to the pyloric lymph nodes along the gastroduodenal artery and the superior mesenteric lymph nodes along the SMA. All of these ultimately drain into the celiac lymph nodes. As for the innervation of the duodenum, the sympathetic fibers derive from the greater thoracic splanchnic nerves arising from T5 to T9, the lesser thoracic splanchnic nerves from T10 to T11, while the parasympathetic fibers derive from the vagus nerves. Together, these fibers of both the SNS and PNS go to the celiac and superior mesenteric plexuses that surround the roots of these arteries. Here, the sympathetic fibers synapse in prevertebral ganglia such as the celiac and superior mesenteric ganglion and send their postsynaptic sympathetic fibers through the periarterial plexuses following the pancreatico-duodenal arteries. The parasympathetic fibers, on the other hand, just pass through the celiac and superior mesenteric plexuses as well as the periarterial plexuses and eventually synapse in the intrinsic ganglia found in the walls of the duodenum, giving short postsynaptic parasympathetic fibers to their destination. Both of these nerve pathways eventually send their postsynaptic fibers to innervate the duodenum. Before we move on, let's take a break and see if you can identify the arterial blood supply of the duodenum. Now, after the duodenum, we have the jejunum, which is the second part of the small intestine, beginning at the duodenojejunal flexure, where the small intestine becomes intraperitoneal again. And after the jejunum, there's the ileum, which is the third and final part of the small intestine. There is no clear visible demarcation between the jejunum and ileum, but when we divide the abdominopelvic cavity into 4 quadrants, we can see that the jejunum is mainly situated in the left upper quadrant, while the ileum is mostly in the right lower quadrant. Together, the jejunum and ileum are about 7 meters long, with the jejunum taking the first 2/5 and the ileum the last 3/5 of the length. On the right side of the pelvic cavity, the ileum terminates into the medial side of the cecum at the iliocecal junction. Now, since they are intraperitoneal, both the jejunum and ileum are covered by visceral peritoneum. Where the visceral peritoneum reflects off the walls of the intestine, it creates a double fold of peritoneum called the mesentery, which attaches the jejunum and ileum to the posterior abdominal wall. The root of the mesentery extends from the duodenojejunal flexure on the left side of the L2 vertebra across the ascending and inferior parts of the duodenum, aorta, and IVC, all the way to the iliocecal junction and the right sacroiliac joint. Between the folds of the mesentery, there are the superior mesenteric vessels, lymphatic vessels, and nerves that supply the small intestine, as well as fat tissue. The arterial blood supply for the jejunum and ileum is provided by the SMA, which travels within the mesentery, giving off around 15 to 18 jejunal and ileal artery branches. On their way toward the intestines, these branches connect with each other and form loops called the arterial arcades, which give rise to many straight arteries known as the vasa recta. And here's where the difference between the jejunum and ileum comes in. The jejunum has fewer arcades with larger loops and longer vasa recta, while the ileum has more arcades with shorter loops and shorter vasa recta. Lymphatic drainage of the jejunum and ileum start in specialized lymphatic vessels in the intestinal villi called lacteals. These empty into lymphatic plexuses in the walls of the jejunum and ileum, which drain into a variety of lymphatic vessels and nodes found in the layers of mesentery. Eventually, all these collect into the superior mesenteric lymph nodes. Furthermore, lymph from the terminal ileum drains into the ileocolic lymph nodes. As for the innervation of the jejunum and ileum, the sympathetic fibers derive mainly from the T8 to T10 portions of the greater and lesser thoracic splanchnic nerves, while the parasympathetic fibers derive from vagus nerves. Just like for the duodenum, they all go to the celiac and superior mesenteric plexuses, where sympathetic fibers synapse in the celiac and superior mesenteric ganglia and pass through the periarterial plexuses, and parasympathetic pass through all these plexuses to synapse in the intrinsic ganglia in the intestinal wall, where both pathways eventually continue on to innervate the jejunum and ileum. Remember, sympathetic innervation reduces peristaltic and secretory activity to stop digestion, where parasympathetic increases peristaltic and secretory activity, facilitating digestion. Also, don't forget about sensory information. Visceral afferent fibers conveying pain travel with the sympathetic fibers, and visceral afferent fibers conveying reflex sensations travel with the parasympathetic fibers. Let's take another quick break and see if you can identify the jejunum and ileum, as well as their blood supply. Alright, as a quick recap, the small intestine has three major parts: the duodenum, jejunum, and ileum. The duodenum has 4 parts. Most of the duodenum is retroperitoneal except for the proximal portion of the first part. The duodenum continues with the jejunum at the duodenojejunal junction, which is suspended by the ligament of Treitz. The jejunum and ileum are intraperitoneal structures, where the jejunum is mostly situated in the upper left quadrant and ileum in the lower right quadrant. Another difference is that the jejunum has longer vasa recta and fewer arcades with larger loops, while the ileum has shorter vasa recta and more arcades with shorter loops. The ileum continues with the large intestine at the ileocecal junction. The small intestine is supplied from the celiac trunk and the SMA via the superior and inferior pancreatico-duodenal arteries and jejunal and ileal arteries respectively. Lymphatic drainage follows the nodes of the arteries supplying the small intestine, which eventually go on to drain into the superior mesenteric and celiac nodes. Sympathetic innervation comes from the greater and lesser splanchnic nerves, while the parasympathetic fibers derive from the vagus nerves. Visceral afferents for pain travel with sympathetic nerves, and reflex sensation with parasympathetic nerves. There are numerous vessels and nerves that course throughout the bony and muscular architecture of the thoracic wall, and they provide innervation and blood supply to the structures within and around the thoracic cage. First, let's have a look at the contents of the intercostal space, specifically the neurovascular bundle containing the intercostal nerve, artery, and vein. It is important to remember the order of these structures, with the most superior structure being the intercostal vein, and below it comes the artery, and below the artery, the nerve. To easily remember this, think VAN, or think about a van that's blue at the top, red in the middle, and yellow in the inferior part. The inferior portion of the ribs also have a costal groove, which only provides partial protection for these structures, so they can be damaged during penetrating intercostal injuries or any intervention that requires intercostal access. Now, let's talk about the nerves. There are 12 pairs of thoracic spinal nerves which supply the thoracic wall. They leave the intervertebral foramina as soon as they are formed, dividing into anterior and posterior rami. Now, the anterior rami of nerves T1 through T11 form the intercostal nerves that run along the intercostal spaces along the inferior borders of the ribs, with the third intercostal nerve traveling between the third and fourth ribs. The anterior ramus of nerve T12 that courses inferior to the 12th rib is the subcostal nerve. The intercostal nerves give anterior and lateral cutaneous branches to innervate the thorax and abdominal wall, muscular branches to supply the muscles of the thoracic wall, and they give rami communicantes or communicating branches that connect the intercostal nerves to a sympathetic trunk on the same side. The posterior rami of thoracic spinal nerves pass posteriorly, lateral to the articular processes of the vertebrae in order to supply the joints, deep back muscles, and skin of the posterior thoracic region. Now, the intercostal nerves are either typical or atypical, and the typical ones are the 3rd through the 6th pair. These nerves enter the medial-most parts of the posterior intercostal spaces. Initially, they run with the endothoracic fascia just between the parietal pleura and the internal intercostal membrane. Near the angles of the ribs, these nerves pass between the internal intercostal and the innermost intercostal muscles. From here, they continue to course in or inferior to the costal grooves, running inferior to the intercostal arteries. Keep in mind that the arteries run inferior to the intercostal veins. Near the angles of the ribs, collateral branches arise and run along the superior border of the rib below. The nerves continue anteriorly between the internal and innermost intercostals and supply these muscles and other muscles, and also give rise to the lateral cutaneous branches in the mid-axillary line. Anteriorly, the nerves appear on the internal surface of the internal intercostal muscle. Near the sternum, these nerves turn anteriorly and pass between the costal cartilages to become anterior cutaneous branches. Atypical intercostals are the first two intercostal nerves which run on the internal surface of the first and second ribs, not along the inferior margin in the costal groove, and the 7th through 11th nerves which eventually become thoracoabdominal nerves of the anterior abdominal wall. Most thoracic spinal nerves, specifically T2 through T12, give rise to the dermatomal map of the trunk through their posterior ramus and the lateral and anterior cutaneous branches of its anterior ramus. This dermatomal map extends from the posterior median line to the anterior median line, and it represents the area of skin supplied by the spinal nerves. Exact dermatomal distributions may vary depending on the source, however they are generally agreed upon with certain dermatomes acting as key landmarks. For example, dermatome T4 includes the nipple and T10 includes the umbilicus. Almost there. Let's see if you can identify the typical intercostal nerves in this picture. Alright, finally, let's look at the arterial supply to the thoracic wall, which comes from the posterior intercostal and subcostal arteries arising from the thoracic aorta, the internal thoracic or mammary artery coming from the subclavian artery, and the supreme or superior intercostal artery arising from the costocervical trunk of the subclavian artery, and the superior and lateral thoracic arteries from the axillary artery. With the exception of intercostal space 10 and 11, each intercostal space is supplied by a large posterior intercostal artery and a small pair of anterior intercostal arteries. The posterior intercostal arteries of the first and second intercostal spaces arise from the supreme or superior intercostal artery, which is a branch of the costocervical trunk of the subclavian artery. The posterior intercostal arteries of the 3rd through the 11th intercostal spaces arise posteriorly from the thoracic aorta. All posterior intercostal arteries give rise to a dorsal branch that accompanies the posterior ramus of the spinal nerve to supply the spinal cord, vertebral column, back muscles, and skin. They also give rise to a small collateral branch that crosses the intercostal space and runs along the superior border of the rib below. The posterior intercostal arteries accompany the intercostal nerves through the intercostal spaces. Close to the angle of the rib, the arteries enter the costal grooves, where they lie between the intercostal vein and nerve. At first, the arteries run in the endothoracic fascia between the parietal pleura and the internal intercostal membrane, and then they run between the innermost intercostal and internal intercostal muscles. They have terminal and collateral branches that anastomose anteriorly with anterior intercostal arteries. Now, the ipsilateral pairs of anterior intercostal arteries supply the anterior parts of the upper 9 intercostal spaces. They pass laterally in the intercostal space, one near the inferior margin of the superior rib and the other near the superior margin of the inferior rib. In the first 2 intercostal spaces, they lie initially in the endothoracic fascia between the parietal pleura and the internal intercostal muscles. They supply the intercostal muscles and send branches through them to supply the pectoral muscles, breast, and skin. They're missing from the inferior 2 intercostal spaces because these spaces are supplied only by the posterior intercostal arteries and their collateral branches. Then there are the internal thoracic arteries, previously called the internal mammary arteries, arise in the root of the neck from the inferior surfaces of the first parts of the subclavian arteries. Then they descend into the thorax posterior to the clavicle and first costal cartilage. Then they descend on the internal surface of the thorax lateral to the sternum and posterior to the upper 6 costal cartilages and internal intercostal muscles. After going down past the second costal cartilage, the internal thoracic arteries run anterior to the transversus thoracis muscle. They terminate in the 6th intercostal space by dividing into the superior epigastric and the musculophrenic arteries. They also directly give rise to the anterior intercostal arteries that supply the superior 6 intercostal spaces. There is also the subcostal artery, which is a branch of the thoracic aorta. It courses along the inferior border of the 12th rib and provides blood supply to muscles of the anterolateral abdominal wall. Last but not least, let's have a quick look at the veins of the thoracic wall. The intercostal veins accompany the intercostal arteries and nerves and lie most superior in the costal grooves. There are 11 posterior intercostal veins and 1 subcostal vein on each side. The posterior intercostal veins anastomose with the anterior intercostal veins, which are tributaries of the internal thoracic veins. As they get close to the vertebral column, the posterior intercostal veins receive a posterior branch, which accompanies the posterior ramus of the spinal nerve of that level, and an intervertebral vein that drains the vertebral venous plexuses of the vertebral column. Now, most posterior intercostal veins, specifically those who drain the 4th through the 11th intercostal space, end in the azygous or hemiazygous vein system. The azygous system conveys venous blood to the superior vena cava. The posterior intercostal veins of the first intercostal space enter directly into the right and left brachiocephalic vein. The posterior intercostal veins of the second and third and sometimes fourth intercostal spaces join to form a trunk called the superior intercostal vein. The right superior intercostal vein is usually the final tributary of the azygous vein before it enters the superior vena cava. The left superior intercostal vein usually empties into the left brachiocephalic vein. The internal thoracic veins are the companion veins of the internal thoracic arteries. And one last quiz before the recap. Can you label the arteries in this picture? Alright, as a quick recap, the contents of the intercostal space can be easily remembered as van, meaning the most superior is the intercostal vein, below it comes the artery, and below the artery, the nerve. There are 12 pairs of thoracic spinal nerves that divide into a posterior rami as well as anterior rami that continues as the intercostal nerve. The typical intercostal nerves are the 3rd through the 6th intercostal nerves. Through the posterior ramus and the lateral and anterior cutaneous branches of the anterior ramus, the cutaneous branches of the T2 through T12 thoracic spinal nerves supply the dermatomes of the trunk that extends from the posterior median line to the anterior median line. The arterial supply to the thoracic wall comes from the posterior intercostal and subcostal arteries arising from the thoracic aorta, the internal thoracic and superior intercostal artery, and the superior and lateral thoracic arteries from the axillary artery. The veins of the thoracic wall are the intercostal veins that accompany the intercostal arteries and nerves, and they mostly drain into the azygous system. The posterior intercostal veins of the first intercostal space enter directly into the right and left brachiocephalic vein. The posterior intercostal veins of the second and third and sometimes fourth intercostal spaces join to form a trunk called the superior intercostal vein.
The thoracic wall surrounds the thoracic cavity, which is the anatomical region where viscera, like the heart and lungs, can be found. The thoracic wall contains a variety of muscles, where many of the muscles that cover and attach to the thoracic wall have a primary action elsewhere, such as the arms, neck, and abdomen, and it's their secondary actions that affect the movements of the thoracic wall. For example, the pectoralis major and pectoralis minor muscles overlay the thoracic wall, but they are primarily involved with movements of the upper limb, and their secondary action is to act on the thoracic wall as accessory muscles of respiration. However, the thoracic wall also does have muscles that have their primary action in the thoracic wall, and these are called the true muscles. They are the serratus posterior, levatorис costarum, subcostals, transversus thoracis, and the innermost internal and external intercostals. Let's start with the two serratus posterior muscles. There's a serratus posterior superior muscle and serratus posterior inferior muscle on each side. The serratus posterior superior muscles have their proximal attachment at the nuchal ligament and the spinous processes of C7 through T3 vertebrae, and their distal attachment at the superior borders of the 2nd through 5th ribs. Its main action is the elevation of the superior 4 ribs during inspiration. The serratus posterior inferior muscles have their proximal attachment at the spinous processes of T11 through L2 vertebrae and their distal attachment at the inferior borders of 9th through 12th ribs near their angles. Its main action is depressing the inferior ribs in order to prevent them from being pulled upwards by the diaphragm. Both of these muscles have been shown to have a role in proprioception, meaning that they might make you aware of the position of the body. For example, when you're lying in bed with your eyes closed, these muscles, among others, could send signals to the brain regarding where you are and what's your position in relation to the bed. Next, the levatoris costarum muscles are 12 triangle-shaped muscles with a proximal attachment to the transverse processes of C7 through T11 vertebrae and distal attachments to subadjacent ribs between the tubercle and the angle of that rib. Their main action is to elevate the ribs. Then there are the intercostal muscles, which are a group of muscles that occupy the space between the ribs. The external intercostal muscles form the superficial layer, while the internal intercostal muscles form the inner layer. Now, the innermost intercostal muscles are fibers of the internal intercostal muscles that are the deepest fiber layer and lie internal to the intercostal nerve and vessels. All 3 intercostal muscles have the same origin and insertion. So their proximal attachment is at the inferior border of the ribs above and their distal attachment at the superior border of the rib below. For example, the intercostals at the 3rd intercostal space all attach to the inferior border of the 3rd rib and the superior border of the 4th rib and so on. In addition, they are all innervated by the intercostal nerves traveling in their respective intercostal spaces. The main differences between the intercostals are their fiber orientation and how far they span anteriorly to posteriorly. So let's look at the 11 pairs of external intercostal muscles that occupy the intercostal spaces from the tubercles of the rib posteriorly to the costochondral junctions anteriorly, where the most anterior muscle fibers are actually replaced by fascia called the external intercostal membranes. These muscles run infro-anteriorly from the rib above to the rib below. To visualize this, the fibers run in the same way the fingers of your hand would if you placed your hands in the pockets of your jeans. The lower external intercostals are continuous anteriorly with the external oblique muscles in the abdominal wall. The external intercostal muscles elevate the ribs during forced inspiration. Then there are the 11 pairs of internal intercostal muscles, which run deep to and at right angles to the external intercostals. This means that their muscle fibers run infero-posteriorly from their origin compared to infro-anteriorly like the external intercostals. To visualize this, the fibers run in the same way your fingers would if you were to cross your arms to hug yourself and place your hands on your hips. The internal intercostal attaches to the bodies of the ribs and their costal cartilages all the way to the sternum anteriorly and posteriorly as far as the angles of the ribs. Between the ribs and medial to the angles, the internal intercostal muscles are replaced by fascia called the internal intercostal membranes. The inferior internal intercostal muscles are continuous with the internal oblique muscles in the anterior abdominal wall. The internal intercostal muscles mostly play a role during expiration. Finally, the innermost intercostal muscles are basically the deeper parts of the internal intercostal muscles, and are separated from them by intercostal nerves and vessels. These muscles pass between the internal surfaces of adjacent ribs and occupy the most lateral parts of the intercostal spaces. And just like the internal intercostal muscles, they likely play a role during expiration. Now, take a moment and try and identify some of the structures we have just talked about on these images. Now, let's have a quick look at the anatomy and physiology of breathing. The diaphragm is the main muscle in inspiration, while expiration is usually passive, except when a person is trying to exhale against resistance, like when blowing air into a balloon, or when one's trying to expel air more rapidly, like when coughing or sneezing. Both external and internal intercostals are active during respiration, but their action is mostly isometric, meaning their contraction does not actually cause movement of the thoracic cage. This isometric contraction is to support the intercostal space, especially during inspiration when internal thoracic pressures are lowest. However, during forced respiration, these muscles become more active and will produce movement of the ribs. Let's take a look at this image. Now, take a really deep breath, literally, do it, and see what happens. When undergoing forced inspiration, the external intercostals and part of the internal intercostals called the interchondral portion contract and rotate the ribs superiorly at their posterior axes. The result is the elevation of the ribs and an increase of the anteroposterior diameter. This occurs because the ribs are hinged posteriorly by a fixed vertebral column and anteriorly by a movable sternum. During forced expiration, the interosseous part of the internal intercostal muscles contract and rotate the ribs inferiorly at their posterior axes. The result is the depression of the ribs and sternum and the decrease in the anteroposterior diameter. So, this is to say that the interosseous and the interchondral parts of the internal intercostal muscles have two different actions during forced respiration, even though these muscle fibers have the same orientation. This all occurs because as the ribs move postero-anteriorly, they descend as they run towards the sternum. Their lowest point is approximately at the junction with the costal cartilage, and then ascending toward the sternum. The interchondral fibers of the internal intercostals are medial to this point. Therefore, their fibers are parallel to the slope of the ribs, and their contraction causes the hinged ribs to rotate superiorly based on their biomechanical pull. The interosseous part of the internal intercostal is lateral to this low point, causing its fibers to be perpendicular to the slope of the rib, and contraction of these fibers rotates the ribs inferiorly, pulling them down. Other muscles in the thoracic wall include the subcostal muscles. They are usually well developed only in the lower thoracic wall, and they vary in size and shape. Proximally, they attach to the internal surface of lower ribs near their angles, and distally, they attach at the superior border of the second or third ribs below. This means that these muscles actually cross one or two intercostal spaces. The subcostal muscles run in the same direction as the internal intercostals, and are thought to act in the same way as the internal intercostals. Now, the transversus thoracis muscles have their proximal attachment at the posterior surface of the lower sternum and their distal attachment at the internal surface of the costal cartilages 2 through 6. They are continuous with the transversus abdominis muscles in the anterolateral abdominal wall. They may slightly depress the ribs during expiration and might provide proprioceptive information. Both of these muscles are innervated by the intercostal nerves. Finally, let's move on to the endothoracic fascia, which is a thin layer that lies between the internal aspect of the thoracic cage and the lining of the pulmonary cavities, and attaches the deeper situated costal parietal pleura to the thoracic wall. The endothoracic fascia continues over the apices of the lungs, where it becomes more fibrous and is called the suprapleural membrane. Alright, as a quick recap. The true muscles of the thoracic wall are serratus posterior, levatorius costarum, subcostals, transversus thoracis, and the intercostals. The role of the intercostal muscles in respiration is to support the intercostal space, especially during inspiration when the internal thoracic pressures are the lowest. During forced inspiration, the external intercostals and the interchondral portion of the internal intercostal muscles contract and rotate the ribs superiorly at their posterior axes, elevating the ribs. During forced expiration, the interosseous part of the internal intercostal muscles contract and rotate the ribs inferiorly at their posterior axes, depressing the ribs. The endothoracic fascia is a thin layer that lies between the internal aspect of the thoracic cage and the lining of the pulmonary cavity.